Good afternoon, doctor. My name is EshikaParuchuri. I'm a 10th grader studying in the United States, and I'm very thankful that you're here with me today on my podcast. My podcast is an initiative that is aiming to educate adolescents worldwide, and I am talking with experienced doctors so that I can provide tips for teenagers and how we can take good care of our health.
Okay.
Welcome everyone to the Healthy Teens podcast. Today I'm joined by Dr. Chetan Vaddepally, who is an interventional and transplant pulmonologist at the Eshika hospitals in Hi-Tech City, Hyderabad, India. He has advanced skills and expertise in interventional pulmonology and has thorough, extensive hands-on experience with many procedures, including bronchoscopies, EBUS, and thoracoscopies. He has vast experience in this field. Now, doctor, would you like to introduce yourself?
Yeah, first of all, a very good afternoon, and thank you for making me a part of this great initiative, and I also appreciate you for that. So myself, I'm Dr. Chetan Vaddepally. I'm a consultant interventional and a transplant pulmonologist at Eshika Hospitals, Hi-Tech City.
What is pulmonology?
Yeah, okay. So pulmonology is a specialty in medicine that deals with diseases of the lungs exclusively. So wherein we deal with overall lung health, all the diseases related to lungs, and we also have sleep disorders, critical care involved into our branch.
Okay. What motivated you to specialize in pulmonology?
Okay, that's a difficult question to answer. As such, I started my medical career to be a pediatrician. So, but then after, during the course of my medicine, when I was doing my house surgeonship, I somehow drifted away from pediatrics. So then I wanted to do some branch of a general medicine. Then the second option that was close to me was pulmonology, because I myself, as an asthmatic, right from my childhood, so I've been interacting with quite a few pulmonologists, and I myself have been experiencing respiratory symptoms. So probably that is one reason I had a interest in pulmonology.
Okay, that's very interesting. How important is respiratory health, and what was the impact of COVID-19 on respiratory health in general?
Okay, so how important is respiratory health it's definitely a very important thing. For that matter, every individual organ has its own importance. COVID definitely taught people about the importance of respiratory health, because everyone has seen what disaster lungs can do when they're not working great. Yeah, so definitely a very important organ, because this is one major organ that nourishes every other organ with good oxygen. So it has to function well for the entire body to run in the right way.
What kind of tests do you usually perform to assess a patient's cardiopulmonary condition?
Okay, cardiopulmonary condition, as in it again depends on what symptoms the patient presents to us. So if you want to just look at the overall cardiopulmonary status, probably we have a simplified or a new advanced technology called as CPET, which is cardiopulmonary exercise testing, wherein you get to know from which organ are the symptoms basically from. Either it's purely heart related or lung related. But when you just look at the overall regular monitoring, probably from the lung perspective, you can just get a X-ray, a lung function test to have an overall assessment of what it is. And from the heart side, or ECG, 2D echo, and rest all depends on what symptoms the patients present to us.
Okay. Now let's talk about asthma.
All right.
What is asthma and how does it impact the patients?
Okay, so asthma, as we all know, or everyone's been hearing it right from the childhood. So it is something related with airways of your lungs. So wherein your major airways are going to spasm whenever they are exposed to some sort of trigger. And this might arise right from childhood. And usually the triggers are some sort of pollens, some dust, or some cold food items or drinks that they take, or any sort of toxic fumes. And all these triggers usually cause a spasm. So these people usually experience wheezing, which is some whistle-like sounds coming out when you take a breath. They have a lot of breathlessness. They also have chest tightness or heaviness. Like different people perceive it in a different way, and they might also have cough. So when they are exposed to a trigger, they go into spasm, and that is when they have all the symptoms.
Okay. Is asthma curable?
Okay, so as we were discussing, asthma starts majorly right from the childhood, and it can run in families with some genetic predisposition also. So this allergic tendency that you have might not be curable, but a patient with asthma or who has symptoms of asthma can have 100% control of their symptoms. I cannot say I can cure you of asthma, but if at all you have symptoms, I can get them under control 100%.
Okay. Can you explain what COPD is?
So COPD again is a other kind of obstructive airway disease, which usually starts in adolescence or middle age, and the major triggers for it are smoke or any kind of environmental exposures. There are many other causes of COPD, but at least the major contributing factor or the major risk factor for COPD is smoking. So COPDs have fixed airway obstructions. They also have symptoms of same like shortness of breath, wheezing, and cough, which is more or less persistent.
Okay. And what is the difference between asthma and COPD?
Yeah, very good and practical question for most of the people. So asthma, as we said, is linked to allergies predominantly. There are different types of asthma, like exercise-induced asthma or work-related asthma, wherein you need to have some specific trigger for it. Your asthma usually starts right from childhood, and the symptoms are very variable. They are never like fixed. So you might be absolutely normal today, you might have symptoms tomorrow, or you might be absolutely normal in the daytime, might have symptoms in the night. So the airflow limitation or obstruction in asthma is very variable. But whereas COPD, as we said, is it starts either in adolescence or late middle age. That's after chronic exposure to a stimulus or a particular trigger like smoke, or you have a biomass fuel exposure, or you have a industrial smoke exposure, or for that matter, second-hand smoke exposure. So you need to have some significant time of exposure before you develop COPD. And once a person is diagnosed or has COPD, the symptoms are more or less persistent. Even on their good days, they have a little bit of symptoms. So the airflow limitation or fixed airflow there is progressive and persistent. It is not like variable like an asthma.
Okay. Okay, so now let's talk about pneumonia. What are some of the most common signs and symptoms that patients with pneumonia have?
Okay, so pneumonia is nothing but consolidation or patch in your lungs, and these are usually infective. Consolidations can be non-infective also, but when we talk about pneumonias, it is infective. The infections can be viral or bacterial, or some atypical infections as well, and there can be tuberculosis pneumonias as well. So usually patients come with acute histories. Acute is like in the last few days. So they come with cough, either productive or dry, especially when it is viral, you usually see dry coughs. But if it is a bacterial pneumonia, you more or less tend to spit out some sort of sputum. So cough, which is either productive or dry, then patients have fever, which can be like high grade at times. And then if it is involving a significant part of your lung, patient might have breathlessness, and some patients present with low oxygen saturations. And if the pneumonia is in a peripheral part of the lung, you might have chest pain on that side. So majorly it is cough, fever, sputum production, and shortness of breath.
Okay. Are breathing treatments and inhalers helpful for patients with lung problems?
So inhalers, yes, but not for every lung problem. So as we were discussing about asthma and COPD, wherein we categorize them as obstructive airway diseases. So especially when you have asthma or COPD, wherein you have airway obstruction, that is where inhalers help. And for that particular condition, inhalers are the best treatment modality available.
Okay. Based on what you have seen in your practice, what is the most common disease you come across in pulmonology
Most common disease,
or condition?
I think, like in pulmonology, especially, we deal with a lot of seasonal variations. So now this is a season of flus, wherein we predominantly see viral upper respiratory tract infections or viral lower respiratory tract infections, viral pneumonias. On the other hand, this is a time wherein pre-existing asthmas and COPDs come with exacerbations. So when it comes to summers, we see a lot of non-specific infections, and also there's a lot of seasonal variation when it comes to lungs. But usually, the most common things we see are lower respiratory or upper respiratory tract infections, followed by upper respiratory obstructive airway diseases, that is asthma or COPD.
Okay. What is the most common cause of shortness of breath?
Most common cause of shortness of breath, I can't really tell you, but again, it all depends. Shortness of breath can be because of lung issues per se, or heart as such, or patients can have shortness of breath just because of low hemoglobin levels. So there are multiple reasons of shortness of breath. But if I have to say which is the most common cause, then I have to pull up all the data, which is kind of difficult.
Okay. What are some of the most successful treatments for patients suffering from asthma?
So for asthma, as we said, it's an obstructive airway disease wherein your airways constrict to some stimulus or trigger. So inhalers are the right and the best treatment available for asthma, wherein your inhaler either has an inhaled bronchodilator. When we talk about bronchodilator, it is a drug that dilates your airways, which includes some sort of medications, including inhaled steroids as well. So there are a lot of compositions of inhalers, but overall the best and the right choice of treatment for asthma are inhalers.
Okay. Generally, at what oxygen level do your organs start shutting down?
Okay, again, this is a disease specific issue, because there are certain conditions wherein people are acclimatized to low levels of oxygen. So it is not always just the low levels of oxygen that creates issues. There are other metabolic things that happen when your oxygen levels go down. But the threshold is different for different conditions. Like when there are people who have shunts in the heart, there's a mix of venous and arterial blood. So for them, the saturation forever is 60% or 70%. Even if you supplement oxygen, the saturation doesn't improve. But then they still have a normal function. But otherwise, for a healthy person to be really sick, 88% is what we take cutoff. Anything below 88% might cause issues or start compromising on other organs.
Okay. Are there any lung diseases that aren't curable?
Lung diseases that are curable,
That aren't curable.
incurable.
Incurable.
Okay. Yes, the most feared disease is ILDs. ILDs, as in it's called interstitial lung disease, where there are different subtypes of ILDs, but eventually most of them progress into pulmonary fibrosis, which is irreversible, and that is where the lung transplant picture comes in. So one of the major or the most common disease that is incurable, at least from the lung perspective, is ILD.
Okay. Based on what you have seen, what is the success rate of lung transplants in patients?
Okay, so talking about lung transplant, worldwide data, if you take the pooled up data from International Society of Heart and Lung Transplant Registry, 1 year survival rate is 80%. That is, you do transplant in 100 people, 80 of them would successfully complete 1 year. 5 year survival rate is somewhere around 60 to 70%, which is still improving. because last probably a decade ago it was not even at 60 to 70%. So right now 5-year survival rate is 60 to 70% for a lung transplant, which is actually very good, because we do lung transplant for a patient at a stage where the 2-year survival is less than 50% without a transplant. So 50 to 60% 5-year survival rate is still much better than this.
Okay. Are there any foods or drinks that you recommend that might promote respiratory health?
Nothing that I am aware of. So I would definitely not get into that dietary prescriptions, but probably I would ask them to avoid foods that they are allergic to, because most of us experience some sort of throat discomfort or a slight cough when we eat certain types of foods, especially the refrigerated items. So any people with lung issues, we tell them to avoid cold stored foods and all.
Okay. How do you stay up to date with new treatments and advancements in pulmonology?
So yeah, studying is always a constant process in a medical journey. So we keep going through all the journal publications, and we have a lot of webinars, conferences going on every now and then, wherein people from different platforms or different subspecialties of pulmonology gather together, and wherein we discuss all the newer advancements. So it's probably all the journal articles or the publications and conferences wherein we get to know about all the advancements.
Okay. In your opinion, what are some promising areas of research in pulmonology that could improve patient care in the future?
Promising areas of research, as I said, one crippling disease or one disease that takes a toll on patients' health very rapidly is ILDs. So there's a lot of research going on ILDs already, on how to either prevent fibrosis or stop fibrosis. Unfortunately, we haven't come to a conclusion yet. So probably that is one area where research would further help us in improving patients' outcomes or patients' health. And the other side, India being an endemic country, we have a very high burden of tuberculosis. So tuberculosis accounts to have the highest deaths, more than even cancers. So there's a lot of research again going on in like treatment of tuberculosis, either to come down on the duration of treatment or come with better drugs that are easily tolerable. Like we've already moved out of the era of injections until like 2 to 3 years back. For resistant tuberculosis, it was all injectables. But now for every kind of tuberculosis, we have moved on to oral tablets, which has improved patient compliance and is also coming out with better results. So tuberculosis, ILDs are the major areas. And yes, of course, cancer. But cancer had already seen a lot of research, so we have moved much ahead in cancer.
What is something that you have seen different from when you first started your journey in pulmonology to now?
Something different, then definitely the branch that I'm practicing, that's lung transplant. Because when I was studying pulmonology, lung transplant was just for an exam sake that I was studying about, because we hardly had any lung transplant programs in India that been active that time. So thanks to COVID, people, the general public knew that there's an option called lung transplant, or for that matter, people even knew that there's some specialty called pulmonology. So after that, the lung transplant scenario in India significantly picked up, and we have better programs now. So I never thought I will be pursuing lung transplant in my career. So where I studied lung transplant just as an option for exam, and currently I myself am doing lung transplants, which is actually a significant development in India in the last few years when it comes to pulmonology.
So do you believe that COVID has really opened up a lot of new opportunities in the area of pulmonology and lung transplant especially?
Definitely. Because, see, in COVID, everything was, most of them were just based on some trials. Everyone had their opinions of treating. But end of the day, if nothing worked, transplant was the only option. And that too, people started doing transplants only like probably in the second wave of COVID when all the options were exhausting. And yes, so definitely it changed the perspective of what we see when we see a person with an end stage lung disease who's not responding to any sort of medical managements.
Okay. So, what kind of lifestyle changes can people take to keep their respiratory health good?
Just not respiratory for that matter. Any organ, you have to eat healthy, you have to drink healthy, and like above everything, keep your BMI under control because now obesity is a major pandemic that we have been seeing that takes a toll on a lot of your organs. So be healthy or in the healthy range of BMI. Regular physical exercise as per whatever age that is required. Quit smoking or do not even start smoking for that matter. And when we talk about smoke, it's not just first hand smoke. We also tell them to avoid second hand smoke or passive smoking or industrial exposure per se. Try to have a good air quality indoors and outdoors. So yeah, this should be practiced. As we all know, prevention is better than cure. So when you start practicing all this, you will definitely have a better lung health. And this has been proven again in COVID when people were confined to their homes, people were eating their own home cooked foods. There was mask, people were following respiratory hygiene. So wherein apart from COVID, all other regular respiratory illnesses like flus, asthma, COPDs, everything were pretty much under control. So it's always practicing better health.
So, let's talk about COPD. What is it, and what are some common signs and symptoms?
So COPD, like I've given a brief introduction, it's a kind of obstructive airway disease, but it is secondary to some chronic exposure to a stimulus, like which is 80% of the time cigarette smoke, or for that matter, any kind of smoke, be it like e-cigarettes or like your cigars, any kind of smoke, or industrial exposure, or then your biomass fuel exposure, all that kind of stimulus over a period of time cause COPD. So it's chronic obstructive pulmonary disease, which says it is a chronic disease. So once you are diagnosed as COPD, you are a COPD forever. Unlike asthma, wherein you can have like years together free of symptoms, or again you might experience symptoms sometime later. But COPD, once it starts, you will have persistent symptoms, at least some minimal symptoms, even in your good days of life. So it's never like you are absolutely fine until unless, like, yeah, we try to keep them under control with medications, but eventually it will progress. So it's a chronic obstructive pulmonary disease, which is progressive. Despite medications, it will progress. But yeah, we have got a lot of treatment advancements in COPD right now to stop progression and all. So mainly, it's all about avoidance of triggers or risk factors.
Because smoking is such a addictive habit, and it might be hard to drop it for once and all. How can patients quit smoking and such addictive behaviors?
So quitting smoking or for that matter nicotine addiction is a very difficult thing. It all again depends on how severe or how addicted they are to that. So there are a lot of scoring systems to calculate the nicotine dependence, and based on the values we have a lot of interventions, out of which the most what successful approach is rehabilitation, wherein you might have to encourage the patient, probably with a psychologist assistance and all. And it has to come from the patient himself that, okay, I'll stop quitting. So until unless patient doesn't want to stop, irrespective of whatever interventions you do, we will not be successful. So it is always the acceptance or willingness from the patient that we require to start a smoking cessation program. And a lot of us run smoking cessation clinics, wherein, as I said, depending on the dependence, we have interventions like just a rehabilitation or just give them some emotional or psychological support. And otherwise, we have some alternative therapies like nicotine replacement therapies, wherein you have nicotine gums or nicotine transdermal patches, nicotine sprays, and all. And if everything of this fails, we have drugs to help them quit smoking. But as I said, it has to start with the patient himself who is wanting to stop smoking. So if they don't want to stop, and if the entire family forces them or the entire medical fraternity forces them, we will not be successful in getting them out of it.
Okay. Why do some people have excessive sleepiness during the day and loud snoring at night? Is it a pulmonary condition?
So I would not say it is a predominantly a pulmonary condition. It again involves your airways. So there's something called OSA, which is obstructive sleep apnea. So what happens is people with OSA, when they sleep, the tone of muscles goes so flaccid that the tongue falls back, the airway collapses, and they have this apneic spells in the night. So wherein your oxygen dips down all of a sudden, and there are a lot of other metabolic changes disturbing your quality of sleep and all. So because of this metabolic changes in the sleep, they tend to have excessive daytime sleepiness in the morning, lack of interest in the things that they do, early morning headaches. So these are the major symptoms of OSA. And snoring is a sign or a symptom of OSA. Not that everyone who snores has OSA, but everyone who has OSA has snoring. And it is again directly related to your BMI. So it is directly related to obesity. The more obese you are, the more severe is the OSA. On the other part, we have non-obese OSA also, wherein people are not obese but still have obstructive sleep apnea, wherein the major causes anatomical abnormalities. Either you have a grossly deviated nasal septum, or there are huge adenoids, or there is some anatomical variation in your upper airways. But majorly, it is obesity that predisposes to OSA. And if you have an uncontrolled OSA, that is when you have this excessive daytime sleepiness, snoring in the night, lack of interest, lack of productivity, and all that.
Okay. Let's talk about pulmonary fibrosis. What is it? And usually what percent of patients get impacted due to this situation?
So, pulmonary fibrosis, there are many predisposing conditions that can cause fibrosis. Like any kind of infection in the past can lead to some amount of fibrosis. Like for that matter, we have seen in COVID also, people who had bad COVIDs had fibrosis, but later we realized they didn't affect them much, provided they're off oxygen and all. But the other kind of pulmonary fibrosis that we fear about is that we were discussing earlier is ILD, interstitial lung disease. So irrespective of the subtype of interstitial lung disease, over time they progress into fibrosis. So once the lung becomes fibrosed, it is very much progressive and there's no coming back. And for that matter, there is a subset of patients called idiopathic pulmonary fibrosis. So it's a kind of ILD wherein you don't find any cause. Idiopathic is no cause, but the patient has a pulmonary fibrosis. This is a subset of patient who rapidly progress, and the only curative option for them is a lung transplant. So once the lung sets into full-blown fibrosis, it's always irreversible. As it advances, patient what loses their normal respiratory functions like taking in oxygen and releasing out carbon dioxide. So we have to supplement them with oxygen. And people who tend to build up carbon dioxide, we give them BiPAPs or CPAPs to let the carbon dioxide out. So all that function that the lung does has to be done externally or with help of some supplements.
Okay. Now let's talk about lung transplant. What is it and how does it work?
So lung transplant is nothing but replacing your diseased lungs with a pair of fresh lungs. So where do this fresh lung comes from is we take them from brain dead donors, wherein a person is declared brain dead because of whatever cause, like a road traffic accident or a major bleed in the brain, and they are declared brain dead. And that is when, if the family comes forward to donate organs, we take the lungs out and put them in a suitable recipient who is in the waiting list. So we do lung transplants for a few of indications wherein the patient has end-stage lung diseases. Like a patient can having COPD can progress to an end-stage lung disease. A patient who has ILD can progress to an end-stage lung disease. A patient who has bronchiectasis or cystic fibrosis can progress to an end-stage lung disease. So when we call it as end-stage lung disease, the patient is either on oxygen support, even at rest, or only on exertion. And there are a lot of other parameters that we look at to say it is an end-stage lung disease. And there's no coming back from there. You have already tried all the medical options or alternative surgical options available, and nothing is working, and then we consider lung transplant.
Okay. What is the importance of lung transplant?
So the importance of lung transplant, like I said, the transplant scenario is picking up in the last decade, probably worldwide. So previously there was no much options for ILDs. We were just continuing medications and praying. That's it. But now at least we have a viable or a curable option for people who can opt. So when we talk about lung transplant, it is more of a quality of life benefit more than survival benefit, because for whatever years post transplant they survive, they have a very good quality of life, unlike a pre-transplant patient who is on oxygen support 24/7, sitting idle, can't even walk like hardly 10 meters without support. So they definitely see a lot of change in their quality of life post transplant, be it for that 1 year or 5 years or 10 years. People are surviving even for 20 years after a transplant. So definitely it is a very, what I can say, a promising option for people with end stage lung diseases. But again, it depends on right selection of the candidate for a transplant.
Okay. Usually, what percent of patients undergo this procedure?
What percentage of patients? That's a difficult question to answer. Probably less than 10% of our practice, because at least if I talk about Indian scenario, people are still not aware of lung transplants. For that matter, even some of the physicians or practicing pulmonologists are still not aware of the work that we do. So we are still in a phase where we think lung transplant is very much complicated. It might not have good success rates and all that. So that again, the perspective is changing. There's some awareness coming out from the general public as well as from the medical fraternity as well. So if I, in my practice as a lung transplant pulmonologist or transplant pulmonologist, out of 10 patients referred to me for lung transplant, it is probably one or two that gets actually converted for a lung transplant.
Okay.
So out of the referral that I have, probably 20% land up in a transplant.
So, is it? I mean, not a lot of people may want to donate their lungs, right? Or maybe they might not want to opt for, donation after they're declared brain dead. So, what is the impact that it has on all of those people who are on the waiting list?
So this point is very much like pertinent in Indian scenario, at least when you see so much of taboos around, so much of religious differences in India. So every religion has their own setbacks when it comes to organ donations. But again, thanks to all the organ donation organizations or NGOs who are continuously creating awareness about organ donation, and especially when we talk about our Telangana's organ donation program, which is Jeevan Dan, they are extremely working on creating awareness, and they've been really successful in increasing the organ donation rate. And today, as we talk, Telangana scores the highest number of organ donations in the country. So that is definitely a welcoming sign in India, because convincing a patient or a brain dead family to donate organs is very difficult with all these religious taboos we have. And the other part is at that point of time where the whole family is grieving, and then going and convincing them for organ donation is a bit difficult. But things are definitely changing now. That I mean, there are so many people who know what an organ donation do. Like there are a lot of kidney transplants happening. There are a lot of liver transplants happening. So people are getting aware of what an organ transplant can do. So like just before you were coming, I had an organ call wherein it is a 74-year-old donor. So if that is the scenario right now, then I'm really happy that people are coming forward for organ donations. But otherwise, the waiting list mortality, at least in lung transplant, is up to 20%. So, per se, if I list 100 people for transplant, out of that, only 80 people will be successfully getting a transplant done. The rest 20 die in the waiting list because of non-availability organs. This organ scarcity is very much problematic in the Western world because there's a very big waiting list there. But as of now, here in India, we are still able to make up for it because we haven't had that big waiting list yet. Maybe down the line, we might have to look for alternatives for that.
Okay, so now we will move on to our myth section.
Okay.
Firstly, quitting smoking won't help.
Yeah, it's definitely a myth. So, do I have to explain it?
You can just talk about it a little.
Okay. Quitting smoking will definitely help because once you stop the trigger or the insult, the disease progress hard there. So, like if a patient is already having a COPD and he still smokes, the COPD progresses very rapidly, and the chance of lung cancer in a COPD is very high in active smokers than people who have already quit smoking. Yeah, so quitting smoking definitely helps.
Okay. Masks aren't safe for people with lung disease.
No, they are absolutely safe and they are recommended for people with lung diseases to, I would not say prevent, but at least reduce the exposure of respiratory infections or airborne infections and bad air quality.
Okay. Only aerobic exercise helps people with lung conditions.
It's a myth again. So you can do any form of exercise because having an overall health is must for your lungs to function well, because it's not just the lungs, it is all the respiratory mechanism that has to function well, which includes a lot of muscles. So muscle strengthening, muscle training, everything is a part of pulmonary rehabilitation.
Okay. As a woman, I should not worry about lung cancer. More women die from breast cancer than lung cancer.
This changed in the past. Every woman now has to be worried about lung cancer as well, because if you look at the recent data, the incidence of lung cancer is very much high in middle-aged women these days. So it's probably because of second-hand exposure or the increasing rates of smoking in women as well, and probably their bodies react differently to the carcinogens, unlike males. But it is not like women do not have lung cancer. The incidence of lung cancer in women currently is pretty high, is almost as equal to males.
Okay. If I don't smoke, I should not have to worry about lung cancer.
Nothing like that. So there are a lot of other insults for lung cancer. It's not just tobacco smoke, like we were discussing. It can be any form of industrial exposure, industrial smoke exposure. It can just be passive smoking, or it can be biomass fuel exposure smoke, that can all lead to lung cancer.
Okay. There is no effective treatment for pulmonary fibrosis.
Okay, and this is a bit of maybe I might give you a diplomatic answer. There's no effective treatment. Definitely yes, because none of the drugs available so far are reversing pulmonary fibrosis. The drugs that we have can only slow down the progression, but we have lung transplant as an option when you talk about treatment for lung pulmonary fibrosis, or one curative option for pulmonary fibrosis.
Okay. The new e-cigarettes won't cause lung cancer.
They can, definitely. The data is about to be out, but e-cigarettes are also a risk factor for lung cancer.
Okay. COPD only affects the lungs.
No. So COPD as in like smoking, can affect any organ in your body. Like they can mainly affect your coronaries, wherein you can have coronary artery disease or lead to heart strokes or brain strokes. It can affect your reproductive health. Then it can affect kids, infants with lung diseases. So it's not just lungs, there's a multi-organ damage that's happening in COPD as well.
Okay. So with that, we have concluded our midsection and also our podcast. Thank you so much for being on my podcast today. It was an honor having you. We've gone through a lot regarding pulmonology and lung transplant as well. Thank you for your time, input, and contributions.
So yeah, thank you so much for having me with you in this wonderful initiative, probably to have awareness. So it was a pleasure for me to also be with you today.
Thank you.
Thank you.
And for our viewers, we have a slogan from our doctor.
Nourish your habits to flourish your lifestyle.
Thank you.
Thank you.